Hello everyone, this is Thomas Fraind in Thomas Hutchinson's hospital visit presentation. Our supervising physical therapist during this visit was Dr. Courtney Back. We began our visit with a chart review where we discovered our patient became intoxicated, fell and hit his head, resulting in head trauma on March 21st. He received a CT scan which showed epidural and subarachnoid hemorrhage. He underwent a right craniectomy to undergo subarachnoid hematoma evacuation and subsequently was extubated on the 22nd. This patient is a 51-year-old male. He lives in a 2-story home. His bedroom and bathroom are on the 2nd floor and his family doesn't live anywhere near him, which limits their support. He works as a truck driver and has a history of substance abuse. He is currently taking Dilantin and no other pain meds were noted in his chart. Subjectively, the patient reported feeling sleepy and lethargic, which he contributed to the medications, but he also reported a constant achy pain in his right shoulder region, which is important for us. A cognition screen is very relevant for a patient with head trauma so we can determine the patient's mental status and his ability to follow commands. And during our exam, we recognized that the patient was A&O times 3. He required increased time to answer 2-part questions, was easily distracted, impulsive, and unable to follow greater than 2-step commands. A strength screen was performed to determine his baseline strength and determine his ability to safely perform functional tasks. And this screen demonstrated his upper extremity was within functional limits, as was his lower extremity, except that his right knee flexion extension strength was at 4 out of 5, secondary to local pain reproduction. A gross range of motion screen was performed to determine his functional capabilities and if other mechanical restrictions were present that were not yet identified. The screen demonstrated that his cervical, upper extremity, and lower extremity range of motion was within functional limits, and the patient also reported that his right shoulder range of motion did not affect his shoulder pain. Because head trauma can easily create neurological deficiencies, his reflexes, sensation, coordination, and proprioception were all assessed and found to be functionally intact. We tested the patient's functional ability to determine what his baseline values are and how well he can follow and retain instructions. We determined that he required supervision for all transfers because he demonstrated impulsivity, decreased balance, and decreased safety awareness, difficulty with planning movements needed for tasks. And during the sharpened Romberg test, the patient was unable to stand without loss of balance in a semi-tandem stance with his eyes open or with feet side by side while his eyes were closed. We also performed the Tenetti test where he received a score of 19, which demonstrates he's a high fall risk. During our gait assessment, the patient demonstrated impulsivity, decreased awareness to environmental obstacles, varied cadence and step length, inconsistent heel strike initial contact, decreased arm swing, and loss of balance when he rotated his head during gait. For our medical screening, we checked his vitals in different positions before, during, and after activities to monitor the patient's physiological response to positional changes and with activity. A cranial nerve exam was conducted to assess the integrity of the cranial nerves due to their vulnerability of injury from head trauma. Abdominal palpation was also performed with an emphasis in the right upper quadrant over the liver to rule out liver issues secondary to a potential referred viscerogenic pain pattern in the right shoulder from alcohol abuse. Our assessment from the evaluation recognizes 3 main deficits: cognition, balance, and gait. Regarding the patient's cognition, he presented with issues of attention to the task, impulsivity, executive function, short-term memory, and all of these limit his ability to safely perform transfers and ambulate independently. The patient also presented with balance deficits, losing his balance during narrow stances, when his vision was removed, and when he was perturbed. These limit his ability to perform tasks that require reaching outside the base of his support, when his vision is limited, or during narrow stances, and they all increase the risk for falls and decreases independence at home and within the community. The patient also presented with several gait deviations as a result of poor balance and cognitive deficits, demonstrated decreased attention to external stimuli, reducing his ability to safely negotiate obstacles, and the patient presented with limited ability to vary his cadence on command and becoming unstable during head movements while ambulating. These all increase his risk for falls and decreasing his independence. The short-term goals we made for this patient are: within 1 week, patient will be able to stand with feet in a narrow stance with his eyes closed for greater than 10 seconds without loss of balance to improve safety during transfers and gait. Another goal is within 1 week, patient will improve score on community balance and mobility scale by 10 points to demonstrate improvement in balance and gait to decrease his risk for falls. And although we did not include the community balance and mobility scale in our initial evaluation, this is an aspect of our visit that we would have done differently because of the usefulness of this objective measurement with this specific type of patient population. The long-term goals are: within 4 weeks, patient will be able to independently ambulate 100 feet on even surfaces while turning head for object identification without loss of balance in order to improve safety during community mobility. The other long-term goal is within 4 weeks, patient will be able to independently perform transfers while simultaneously performing a cognitive task without verbal cueing or tactile cueing of proper sequence of movements in order to improve safe household mobility and decrease caregiver burden. For our referral section, we want to make sure that we are requesting discharge consultation with a physiatrist because this patient functions fairly well with his injuries and he may not qualify for acute rehab. Yet his cognitive status and lack of social support make a discharge to home very unsafe. A neuropsychologist should also be referred to this patient to more thoroughly assess the patient's cognitive deficits and to assess the patient's changes in thinking and behavior so we can develop the most inclusive rehabilitative program for this patient. A social worker is also going to be consulted for this patient to discuss discharge options and methods to deal with his substance abuse.
The medical diagnosis can be seen here. However, after examination of the patient and his current deficits, we feel the most appropriate PT diagnosis would fall under ICD code 10 as listed, which is difficulty in walking, unsteadiness on feet. While there are many deficits presented with this patient medically, we feel this is the most appropriate PT diagnosis based on his functional deficits. Based on the diagnosis and his current representation of function, the prognosis for our patient is good. We expect that he will be able to be back in independent living within 12 to 24 months, with the greatest gains seen within the first 6 months. The typical prognosis for a patient with this diagnosis is around a 1 to 2 year time frame. However, there are several factors that can affect a patient for a better and more prolonged recovery. For our patient, the positive factors were his age, as he was younger than 55 years. He was able to receive the required surgery quickly from the time of his incident, high FIM levels, and did not fall into any state of comatose at the time of his incident or any time while in the hospital. Some negative factors that influenced his prognosis were an overall lower educational level, performance of a craniectomy, and a secondary occurrence of an epidural hematoma as well. Based on his diagnosis and expected prognosis, we feel the most significant things that the plan of care should work on are improving his functional mobility and tasks for the remainder of stay, continuing the integration of cognitive tasks during his interventions, continuing to work on ADL and functional activity interventions, and early intensive rehab beginning at 20 days post-op. So overall, our emphasis for our plan of care is to improve functional movement and regain independence while secondarily restoring neurocognitive factors, increasing environmental awareness, and education on the extent of his injury. The decision for discharge was the most challenging in regards to deciding the most appropriate place. Our patient was able to perform most of the required tasks to remain admitted in the hospital. However, his inability to make the most appropriate cognitive and executive decisions were not at an independent level, thus increasing his risk for re-injury if sent home unsupervised. After discussing our options, we felt that a discharge to a brain injury rehab unit or a BIRU would be most appropriate, as the emphasis of his rehab would be neuropsychological. Discharge to a BIRU would allow the rehab to focus on cognition, skill modification, speech, functional tasks, and provide the 24 supervision he needs. It was also suggested by Hall that those most fitted for a BIRU are those who are well enough to live in the community, but do require supervision in a structured environment to benefit from continued therapy. Based on his current deficits, the most appropriate interventions for our patient would focus on balance, gait, and cognition. Improvements with his balance would be helpful in order to improve his safety with all transfers and mobility, thus reducing his risk for falls. Examples of interventions are listed below. Improvement with his gait would allow for more safe and functional mobility, increase his independence in order to get him back home. Some of those interventions are also listed below. Cognition is also a key factor to his rehabilitation. The integration of cognitive and executive function throughout his balance and gait deficits would allow for the introduction of multitasking interventions in order to challenge him to regain his maximum potential functional independence. With these interventions and expected improvements to be made, some key re-examination techniques would be a strengthened range of motion in order to demonstrate improvement in his mechanical function and readiness for progressing functional mobility, as well as re-examination of the initial standardized outcome measures that were taken in order to demonstrate improvements on those as well. The overall experience of this visit provided us the opportunity to enhance our skills while also allowing us to recognize some things that we could improve on. For this particular patient, we felt that we could have handled the patient's impulsive habits in a safer manner by initially setting the tone at the beginning of the exam by making sure that he was aware of our goals for the session and the pace at which we would be performing our exam techniques and interventions. We also felt that improvements could have been made in regards to the efficiency of how we prioritized our exam components. For example, we could have reduced the amount of time spent on our exam and changing positions and have better recognized the most significant exam findings. Also, we were not familiar with the community balance and mobility scale prior to the visit and feel it is one that would be beneficial for us to have in the future. Overall, we feel that this visit has made us more familiar with an acute care setting and has shown us the importance of efficiency while working with the patient on an individual level and also on a multidisciplinary level in regards to interprofessionalism. We also realize the importance of keeping attention to the task at hand for a patient in regards to making sure they are completing their interventions in the most effective and efficient way possible, but also for us as PTs to make sure that we are able to get all of the most pertinent information we can without losing focus. Also, being able to make sure that a patient is discharged to the most appropriate place is something that is not always the easiest due to the complexities of the healthcare system. The importance of this lies within the ability of the therapist's interactions with those who can be most helpful under the certain circumstances, such as a social worker and fellow therapist. But overall, the key is to work as a team and to ensure that the patient is placed in the most appropriate setting and ensure that it is always quality care above all.
And these are our references. Thank you for watching.